So thank you so much to the organizers for having me. It's really such a pleasure to come out here, such a lovely city, and it's not spring in Canada right now. It clearly is spring here, so you know it's a nice foreshadow of what is coming in Canada. Okay, let's get started. So sometime in the 1990s, an organization called the Abigail Alliance pressed a case to the Supreme Court of the United States, arguing that patients have a constitutional right to getting access to unproven interventions. Now, the Supreme Court ultimately decided not to hear that case, so the case was not successful. It left intact the regulatory authority of the Food and Drug Administration, but it was one of the sort of relatively early cases where you had patients arguing that we ought to liberalize patient access to unproven interventions. But that wasn't the first time that we'd had debates and discussions around patient access to novel interventions outside the context of clinical trials. In the early 1990s and throughout the 1990s, actually throughout the 80s, also there was a movement among HIV/AIDS activists that also pressed for more liberalized access to unproven interventions. Now, these movements have typically framed debates about access to unproven interventions in two key ways. The first way that this is often framed is in terms of a trade-off between private and public interests. On the one hand, you have the private interest in patients making risk-benefit judgments in accordance with their own preferences versus the public interest in protecting the public from unsafe and or ineffective drugs. The other way this is commonly framed as a trade-off between innovation and caution. On the one hand, we want to liberalize ability to test new interventions in patients. On the other hand, if we liberalize those too much, we can cause harm. We want to protect patients and be cautionary in research approaches. Now, I want to suggest that these two ways of framing debates about liberalizing patient access to novel interventions are really inappropriate ways to understand debates about access to unproven interventions outside the context of trials. Instead, what I really want to argue is that when we talk about liberalizing patient access to novel interventions outside of clinical trials, what we're really talking about is how we want to distribute the costs and burdens of medical uncertainty in society. So I'm going to make this argument in 5 parts. First, I'm going to give you some background about various schemes for allowing patients to get access to drugs that haven't yet proven to be safe and effective. Secondly, I'm going to talk about, I'm going to rebut that argument about this being framed in terms of private versus public interest. I want to argue that there aren't really any strong private or personal interests in getting access to unproven interventions outside of trials. Thirdly, I want to rebut the framing of this as being an issue of innovation versus caution. I want to argue that actually restricting patient access to new drugs or at least conditioning access to new drugs on participation in clinical trials actually drives innovation rather than impedes it. And then lastly, fourthly, I want to anticipate some responses and rejoinders to my argument. And then I want to close with talking about how patient access to novel interventions outside of trials is really a discussion about how we want to distribute the costs and burdens of medical uncertainty. Okay, so let's start with some background. Probably most people here know a bit about drug development, but it's worthwhile going through the various steps in developing a new drug. So all new drugs start off their clinical development process in phase 1 clinical trials. Phase 1 trials are primarily aimed at testing safety, also establishing information about dose and pharmacokinetics. A drug will then advance to phase 2 clinical trials, which is the first occasion to actually test the efficacy. Typically, the efficacy is tested using what's called a surrogate endpoint, which is an indirect measure of a drug's efficacy. If you get signal of efficacy in phase 2 studies, and if you don't have any untoward safety events, the drug would then advance to phase 3 clinical testing. These are the large randomized controlled trials, often using clinical endpoints that are used to establish a licensure at this point of to allow marketing of that drug. And at that point, further testing of the drug is typically done under the auspices of phase 4 clinical trials. Now, there are 4 different schemes and regulatory schemes that are aimed at trying to liberalize patient access to new drugs, that are aimed at expediting the ability of patients to get access to drugs that haven't yet proven safety and efficacy. The first scheme is called accelerated approval. There's an equivalent in the European Union as well. Here the idea is that if you have a drug that treats a life-threatening illness, that drug can get approved on the basis of phase 2 clinical trials if you have positive signal on a surrogate endpoint, and that surrogate endpoint is expected to correlate with clinical endpoints, things like survival or quality of life. The second major scheme is, in the US at least, called breakthrough designation. Also, there's different programs that are very similar, priority review and fast track. Here the idea is that a drug still has to pass through the various stages of clinical development, but because of increased interaction with regulatory authorities, the period of testing is actually a little bit compressed, so you get a more rapid approval of a drug. And this is restricted for drugs that are aimed at treating illnesses that really don't have any viable treatments already available. A third mechanism is called expanded access. Here in Europe, it's called compassionate use. And here the idea is that sponsors are permitted to distribute their drugs, not charge for them, but to distribute their drugs to patients who might want to access them before those drugs have completed phase 2 and phase 3 clinical trials. Now, patient access in this case is conditioned on a patient being ineligible for participation in a clinical trial. And the fourth mechanism, not really an established mechanism, but it's sort of a cluster of different policy debates, at least in North America. Probably there are some debates that are parallel in Europe, although maybe not to the same degree. I'm just calling this right to try movement. And here the idea is that, you know, at least some groups, particularly this is led by libertarian groups in the United States, argue that patients ought to be able to access unproven drugs after they've completed phase 1 clinical trials, but before they've done phase 2 and phase 3 clinical trials. So this is analogous to the argument that was made by the Abigail Alliance when they pressed for patient access to unproven drugs and when they pressed for diminishing FDA's authority to restrict patient access. Okay, so let's get to the first argument, the first sort of inappropriate framing of the debate about patient access to novel interventions. So again, people often argue that there's a personal interest, patients have a private interest in accessing unproven drugs outside the context of clinical trials. I want to offer actually 4 different reasons why I think I forgot to change the slide, 4 different reasons why I think this is an inappropriate way to understand this issue. The first point I want to make is that to a surprising degree, a lot of drugs that are approved by the EMA as well as the FDA actually don't have any benefit at all. It's kind of surprising. You think of drug regulation as being really, really stringent and having high demands on evidence to license a drug, but in fact there are numerous cases of drugs that have gotten approved based on very equivocal evidence of efficacy and safety. So the first point I want to make, I mentioned this already, is that often there's this sort of clinical trials often use surrogate endpoints. These are indirect measures of benefit. So for example, in cancer, tumor shrinkage is a surrogate benefit. It's thought to correlate with clinical benefit, things like survival or quality of life, but often there's a slippage between surrogate endpoints and clinical endpoints. And to a surprising degree, many drugs for life-threatening illnesses, particularly in realms like cancer, are approved on the basis of surrogate evidence, not clinical evidence. So for example, a 2017 analysis of all approved cancer drugs in the European Union by the EMA found that only about a quarter of drugs were approved on the basis of survival information at the point of approval. If you waited 3 years after approval, evidence that there was a survival advantage for the cancer drug increased to about 33%. So most drugs, cancer drugs that are approved in Europe, are not actually established as prolonging survival. Now, if you actually look carefully at the drugs that are approved for on the basis of extending survival, only about half of those drugs, or 1/6 of all the cancer drugs, actually extend survival in a meaningful manner, meaningful here defined by the European Society of Medical Oncology. It's basically a survival benefit of 2 months or more. So only about 1/6 have actually any sort of meaningful survival advantage. There's also any number of examples. I'm just going to give one example here of drugs that have been approved, in this case by the FDA, on really surprisingly weak evidence of efficacy. This is a drug called eteplirsen. This was approved for treatment of Duchenne's muscular dystrophy. It was approved on the basis of a clinical trial that enrolled 14 patients that used muscle biopsies and dystrophin expression, which is a surrogate endpoint, not a clinical or functional endpoint, and there was no comparator group in this trial. But nevertheless, this drug got approved. So the bottom line is even accessing drugs that are approved by FDA and EMA often actually isn't associated with major benefit. The second reason why I think there's not a clear private interest in accessing unproven therapies outside the context of clinical trials has to do with the very nature of what a therapy is, the philosophy of therapy. So all drugs begin as ineffective and unsafe interventions, and through the arduous process of clinical development, they're transformed into therapies. And you can think of that process as consisting of two key steps. In the first step, researchers have to identify the materials, practices, and beliefs to combine with that drug in order to elicit its clinical activity. Drugs don't do anything at all unless you know exactly what dose to use, what kinds of side effects to look out for, what kinds of co-interventions to use, et cetera. So I call that collection of materials, practices, beliefs combined with a drug an intervention ensemble. So for example, if you're developing a cell therapy for amyotrophic lateral sclerosis, you would need to know what dose of the cells to use, what kind of immunosuppression regime to use in patients, when to deliver the drugs relative to the course of ALS, combine that with the cells in order to elicit its clinical activity. So that's the first step, is to identify those various conditions to elicit the activity. And the next step, having identified those approximately optimal conditions, is to rigorously test the efficacy of those approximately optimal conditions in randomized controlled trials. That's largely what happens in phase 3 clinical trials. So you can think of that first step that I described, building the intervention ensemble, as akin to exploring a multidimensional landscape. Here I've just graphed a dose versus disease stage with the aim of trying to find the approximately optimal conditions for therapeutic efficacy. The point that I want to make here is that at the point where drugs are in early clinical development, you don't have a therapy at all because you don't even know the conditions to combine with that intervention in order to elicit its activity. That's the very point of early phase trials. So I think it's a mistake to even think of interventions that are in early phase studies as having therapeutic properties. The third argument I want to make is that if you actually look at the evidence for risk and benefit for drugs that are in clinical development, it's clear that, or at least it seems for the most part, patients don't really benefit by accessing unproven drugs, even within clinical trials. So first, this is kind of an obvious point, but it's worth kind of reinforcing it. First, I just want to make clear to everyone that most drugs that begin the process of clinical development never vindicate their safety and efficacy in clinical trials. So for example, in cancer, for every 20 drugs that are put into phase 1 testing, only one of them will eventually prove to be safe and effective enough to receive a regulatory license. If you go to areas like neurodegenerative disease, it's basically a 0% batting average. If you actually look at the risk-benefit balance within early phase trials, generally risks and burdens are almost certain. Benefit is, for the most part, speculative. These are data from, for example, several different meta-analyses of risk-benefit in phase 1 cancer trials. There's a lot of numbers here. All you need to know is that on average, about 0.5 to 1% of patients experience drug-related deaths, about 15% of patients experience life-threatening toxicities, and only about 5% or so of patients in phase 1 cancer trials experience major tumor shrinkage. Now again, remember, tumor shrinkage is a surrogate endpoint, it's not a clinical endpoint, so there isn't necessarily a clear correlation between having your tumor shrunk, again, that's only 5% of patients, and actually extended survival. You can look outside of cancer and other disease areas. My own lab, just one other figure here. If you look at the number needed to treat, so the number of patients that need to participate in a phase 1 trial, in order for a single one of those patients to get a drug that will eventually be proven safe and effective, it's about 1 in 70. So 69 patients out of 70 patients in phase 1 trials will be accessing a drug that's never going to get approval in their indication. If you go to phase 2 clinical trials, it's 21 out of 22 patients will access a drug that's not going to get approved in their particular indication. Now, you can look outside of cancer in other disease areas. This is Alzheimer's disease. We've done a meta-analysis looking at whether patients benefit by getting access to unproven Alzheimer's medications within clinical trials. And what we see in our meta-analysis is that there doesn't seem to be any treatment advantage, even if you aggregate across all 20,000 patients who have participated in Alzheimer's clinical trials. And yet, drug-related withdrawals from clinical trials, as well as serious adverse events, are statistically significantly elevated in patients accessing new drugs as compared with patients getting the placebo. Basically, in Alzheimer's clinical trials, the best place to be is in the placebo arm, not in the treatment arm. Okay, the fourth argument I want to make is that the evidence that is often supporting the development of drugs in early phase development, not always, but oftentimes, is actually very weak evidence. There's been a literature over the last 10 or 15 years documenting any number of different problems with the ways that animal studies, non-human animal studies, are designed, reported, and taken up. And in fact, it's not too surprising because it turns out that regulatory authorities like the FDA or the EMA don't actually demand high-quality preclinical evidence of efficacy in order to launch a phase 1 or a phase 2 study. They certainly demand high-quality risk evidence, but not high-quality efficacy evidence. So this is a statement from the FDA's guidance for submitting a phase 1 clinical trial. It basically says that they're not carefully scrutinizing the evidence of efficacy. And here's a statement from longtime FDA veteran Bob Temple, where he basically says that FDA isn't really carefully looking at evidence of efficacy when they authorize a phase 1 or a phase 2 clinical trial. And so not surprisingly, it's possible to go to the literature to find cases of drugs and cell therapies and other kinds of interventions that have been put into clinical trials, phase 1 or phase 2 clinical trials, in spite of the fact that the non-human animal evidence was in fact negative. Here's just one of several different examples. This is for a cell therapy for treatment of spinal cord injury. In this case, there was preclinical evidence suggesting that cell preparation was not effective, and yet the trial went forward anyway. So the bottom line is, it's not clear to me that patients have any personal interest in getting access to drugs that have not yet been demonstrated to be safe and effective. At least they don't have necessarily interest outside of clinical trials in accessing those interventions. For the most part, accessing drugs that have not yet demonstrated safety and efficacy is mostly exposing yourself to risk with the slimmest and most remote prospect of major benefit. Now, you might argue that patients have a personal interest in having an extra choice available to them. If they have advanced disease, patients might value the option of getting access to an unproven intervention. But it's not clear to me that medicine has any obligation to provide that option to patients. If we were to say that medicine is in the business of providing patients choices, and those choices are uncoupled from evidence, we would also have to argue that medicine has an obligation to provide homeopathy and any number of other kinds of alternative interventions that don't really have any kind of evidence behind them. So I sort of reject the view that there's any particular personal or private interest in getting access to unproven interventions outside the context of clinical trials. Okay, let's look at my second argument, my second sort of reframing here, innovation versus caution. What I want to argue here is that restricting patient access to interventions, or at least conditioning access on participation in a clinical trial, actually drives innovation rather than impedes it. And there's sort of three different ways I want to make this argument. The first I want to argue is that by restricting patient access to interventions, that coupled with strong intellectual property regimes creates incredibly powerful economic incentives to innovate and to produce high quality evidence of an intervention's safety and efficacy. So before a drug actually gets approval, regulatory authorities like the EMA have very, very strong influence in shaping the ways that trials are conducted and what trials are conducted to establish safety and efficacy. And as a result, because the company, if they want to make a profit, they have to demonstrate high quality evidence of safety and efficacy. Companies have very, very strong financial incentives to invest the necessary resources in developing a safe and effective drug and proving it as being safe and effective. That incentive vastly diminishes after a drug actually gets regulatory approval. After a drug is approved, companies actually don't want to invest a lot of resources in proving safety and efficacy because after all, if they run a clinical trial, there's some risk that they're going to produce evidence that's going to lead to withdrawal of their product. So at the point where drugs actually can be marketed, incentives begin to dissipate, if not evaporate altogether, for producing high quality evidence of safety and efficacy. And there's many different ways to illustrate this. I'm going to illustrate this with the case of accelerated approval. When drugs get approved on the basis of phase 2 clinical trials, often regulators condition that approval on completion of further clinical trials. There have been a number of different studies that have looked at how quickly sponsors actually complete those post-approval studies after accelerated approval. This is one study from 2011 that found that only about a third of interventions that are approved on the basis of surrogate endpoints complete further clinical trials nailing down efficacy of their intervention on clinical endpoints, or complete other studies that are aimed at establishing the safety of the intervention. So again, greatly diminished incentives to produce high quality evidence of safety and efficacy once a drug gets approved. Secondly, conditioning access to novel interventions on participation in a clinical trial maximizes the efficiency of innovation. Again, there's many ways to argue this. I'm going to illustrate this with a particular debacle in the history of medicine, the development of autologous bone marrow transplantation for high-dose chemotherapy for the treatment of metastatic breast cancer. This was a regime that was developed in the early 1990s, late 1980s. The basic idea was that you could deliver higher doses of chemotherapy to women with metastatic breast cancer if you removed their bone marrow, you banked the bone marrow, you hit the women with higher doses of chemotherapy, and then you return back the bone marrow to the women so that they could restore their lymphocytes and whatnot. It made a lot of mechanistic sense for improving survival for women with metastatic breast cancer. And in fact, there was a small clinical trial that suggested significant promise for this intervention. It was widely endorsed by some very important figures in the United States, and it quickly passed into standard of care at certain medical centers in the United States. Over the course of the 1990s, about $3.4 billion were spent delivering this intervention, and about 43,000 women had exposure to this intervention. It ended up taking about 10 years to conduct rigorous randomized controlled trials testing ABMT high-dose chemotherapy against what had been the standard of care for treatment of that disorder. It took 10 years because it was incredibly difficult to recruit enough women to participate in that study and to agree to be randomized to what many people perceived as yesterday's standard of care. When that study was ultimately published in year 2000, it turned out that there was no survival advantage for ABMT high-dose chemotherapy, but there was substantially greater toxicity for women receiving that intervention. Finally, another reason why conditioning access to unproven interventions to participation in clinical trials is key to promoting intervention is that it helps to sort of maintain high levels of confidence in the research enterprise. Again, there's different ways to illustrate this. I just want to sort of point out that when you have major mishaps in clinical development, that can often destabilize confidence and trust among different stakeholders like regulators, patients, funders, members of the public, et cetera, and that can undermine other relatively fragile research endeavors that are related to that area. So a good illustration of this is the case of gene therapy in 1999. There was a death following of a relatively healthy volunteer in a phase 1 clinical trial, and many people believe that that death ended up actually slowing the pace of development of gene therapy because funders, private sponsors, et cetera, were less willing to invest in this otherwise very promising research area. So I think it's important to recognize that conditioning patient access to new interventions on their participation in clinical trials that are aimed at demonstrating safety and efficacy is a key way of actually maximizing the efficiencies of innovation. It's not compromising innovation, it's actually driving innovation. Now, there are a couple of different responses that people might make as rejoinders. Let's see, how much more time do I have? Just want to make sure, because it says here, Good, I'm fine. The number up here makes it seem like I've gone way over, but okay. Okay, good. So there are a number of different sort of responses and rejoinders that people who advocate for patient accessing drugs outside of interventions might make, and I want to anticipate those. So one argument people might make is that allowing patients to get access to unproven drugs helps to sustain their hope. That may be true, but medicine is not just an art, it's also a science. And what's key is that you have a proper complementarity between the art of medicine and the science of medicine. Physicians don't give patients unsafe, potentially toxic drugs merely to sustain hope. They only give patients drugs that are not proven if there's an expectation that drug may have a benefit for those patients. As I've shown you in the first part of my talk, there isn't really any clear evidence to suggest that allowing patients to get access to unproven interventions actually has a benefit. The second argument that people often make is that patients have nothing to lose. If you have advanced disease, you have nothing to lose by accessing an unproven intervention. Actually, I don't think that's true. I think patients have a lot to lose. There are any number of different studies that show that patients, when they have advanced disease, if they begin discussions about hospice care and palliative care, they actually ended up having a much higher quality of life or quality of death in many cases than patients who postpone discussions about palliative care or hospice care and pursue curative treatments up until the end. So patients actually, there are better and worse ways to die, and pursuing curative therapy that has the most remote prospect of benefit often can postpone the kinds of transitions that patients need to make when they have advanced disease towards palliative care. The third argument people might make is, well, patients have a right to access whatever drug they want. They have a right to their own risk-benefit judgments. It's not up to medicine to paternalistically restrict their decision-making authority. And I guess, I would say that rights always have limits. I might have a right to control my property, but that doesn't necessarily give me a right to build an oil refinery on my property. If that oil refinery is going to pollute my neighbor's water or my neighbor's land, the government has a legitimate interest in restricting my ability to build an oil refinery on my own property. And I would say it's an analogous argument in the case of accessing unproven interventions outside of clinical trials. I've just made the case that if you liberalize patient access to unproven interventions, essentially what you do is you prolong the period of development of a drug. You are thereby compromising other patients' ability to eventually access a proven safe and effective drug. That's an economic externality, and I think governments have a legitimate interest in constraining private transactions in order to reduce those kinds of externalities. Now, I fourthly want to acknowledge that there may very well be exceptions. There are probably cases where it may make sense to allow patients to get access to unproven interventions outside the clinical trial setting. And these are sort of 5 conditions that I would say need to be fulfilled. Number 1, a patient ought to be ineligible for a clinical trial, and/or there should probably not be the prospect of a clinical trial being initiated in the near term. Secondly, any patient access to an unproven intervention outside trial should be guided by some kind of protocol. There should be independent review of risk-benefit balance, some sort of a merit review of that protocol. Implementation of that protocol for the patient should be coupled to rigorous data collection, and there should be very strong expectation and commitments that physicians who provide innovative therapies outside of clinical trials will publish in full the outcomes for those individual patient compassionate use applications. Okay, let me now close by talking about what I think the core debate ought to be about when we talk about liberalizing patient access to unproven interventions, and that is the way that we distribute the costs and burdens of uncertainty. So medical uncertainty is incredibly costly and burdensome. It's costly because our healthcare systems end up paying for interventions that end up being proven to be unsafe and ineffective. It's burdensome for patients because patients are often accessing interventions that are unsafe or ineffective. How we decide when to allow patients access to new interventions is one of the key fulcrums on which the way we distribute the costs and burdens of medical uncertainty pivots. And there's sort of three different ways that that redistribution can potentially occur. The first is that if you liberalize patient access to unproven interventions, again, outside of clinical trials, you are essentially shifting the burdens of drug development from relatively privileged populations to relatively underprivileged populations. I say privileged because generally speaking, early phase clinical trials enroll patients who are relatively advantaged, at least in the United States. They tend to be whiter and more affluent, and they tend to have less comorbid disease. As well, these are patients that tend to be the healthiest among the sick, so they have fewer comorbidities, et cetera. If you approve a drug, that means that that drug is going to actually be used out there in the wild in clinical settings where you're going to have exposure to relatively less privileged populations are going to have exposure to that drug. The second key sort of fulcrum against which this pivots is the private versus public. So prior to drug approval, the costs of drug development are almost entirely borne by private drug developers. Those are the entities that stand to profit from marketing these drugs downstream. That seems fair and appropriate. Once a drug is actually approved, again, because there is vastly diminished economic incentives to conduct clinical trials at that point, the costs of residual uncertainty on that intervention are now carried by the public sector, either through funding of clinical trials, public funding of clinical trials, or through the very sort of the public healthcare sector, which pays for treatments that don't necessarily have clear evidence of safety and efficacy. The third way that altering the point at which you approve a drug shifts the distribution of the burdens and costs of new interventions is from shifting from consenting populations to non-consenting populations. When you restrict access to a new intervention to patients that participate in clinical trials, you ensure that those patients are accepting that risk benefit under conditions where they've been provided a very rigorous informed consent process. We all know clinical trials often have a very demanding informed consent process. We also know that in the care setting, informed consent is much less weaker. We don't have nearly as demanding a process for conducting informed consent in the care setting. So if you liberalize patient access, if you approve drugs earlier on, it means that the uncertainties around those drugs are being borne by patients who are getting exposure to that drug in settings where they haven't necessarily provided rigorous informed consent. So the net upshot of what I'm arguing is that by conditioning patient access to unproven interventions to patients that participate in clinical trials, you are promoting a much more equitable distribution of the costs and burdens of medical uncertainty. Now I want to close with a couple, just one last key point. Everything I've talked about now is about regulatory approval. So I haven't so much talked about how we ought to control risk-benefit prior to regulatory approval, how we ought to shape clinical trials, what kinds of patients ought to participate in clinical trials. But I want to suggest that the same key arguments that I've made here could also be applied to decision-making about what kinds of patients we allow to participate in clinical trials. And I'm going to illustrate that with one key example. Oftentimes in testing a new intervention, there are debates and discussions about how aggressively we ought to pursue a clinical development program. For example, if you're testing a new treatment to control neurodegenerative disease, oftentimes there's a debate about whether or not to test that drug in patients with relatively recent disease onset. Those patients have a much greater prospect of benefiting from the new intervention because their disease hasn't progressed as far, versus testing the drug in patients with advanced disease. These patients are much less likely to benefit because their disease has already progressed, but there's much less risk for those patients because those patients have much less to lose if in fact there's a serious adverse event in that clinical trial. So often there's a debate in early phase drug development for testing interventions about which patient population to enroll. And I want to suggest that my arguments would generally favor an argument for initially enrolling patients with advanced disease and only later enrolling patients with more recent onset disease. So first, one of the arguments that people make is that patients ought to have the right to have their own risk-benefit judgments, and many people would argue that getting enrolling early onset disease patients allows patients to exercise that right, but I've argued throughout this talk that in fact, at the point in which you're developing a new intervention, risk-benefit balance is very unfavorable. You're almost certain to experience side effects. The prospect of major benefit is extremely remote, and it's extremely remote in part because you don't even know how to use the drug, much less whether or not the drug is effective. The second argument people make for enrolling patients with recent disease onset instead of patients with advanced disease is that it will accelerate innovation. I want to suggest that actually it can potentially impede innovation. If you expose patients with a relatively good prognosis, a patient that has a high quality of life, to an intervention that proves to be unsafe, that can lead to exactly the kinds of crises of confidence that led to a withdrawal of support for gene therapy for 5 to 10 years. And it's exactly those conditions that you want to avoid early on in drug development. That would favor trying to test an intervention initially in patients with advanced disease and trying to nail down things like dose or stage of disease in which to use the drug initially in those advanced disease patients. And then once you've sort of nailed some of those elements down, delivery, et cetera, then you advance to patients with more recent onset. And then if you've established at that point some evidence of efficacy, then advancing that drug into testing even more vulnerable populations like children. So generally, what I would favor is an approach that tends to escalate risk from as you advance from patients with advanced disease through to patients with more recent disease onset. So the bottom line, the last thought that I just want to leave you with is that oftentimes when we discuss the question of when patients ought to get access to new interventions, as well as when we debate questions about which patients ought to participate in clinical trials, a lot of what we're discussing is how we ought to distribute the costs and burdens of medical uncertainty. And I think there are a lot of compelling reasons to try to distribute the costs and burdens of medical uncertainty in as equitable a manner as possible. Thanks.
When you talk about the informed consent process being very rigorous with clinical trials, do you think that they are as clear as you were today about the risk of the low risk of efficacy relative to greater risk of toxicity? I mean, I've looked at informed consent documents from very controversial clinical trials like the support trial. I guess you know what I'm talking about, the oxygen for neonates. And nowhere were those parents told their children were at risk of death from those trials, depending on what group they fell in, or risk of blindness. This is a real, I think it's important that we have ethical approval and to make sure that the informed consent documents are clear. But I'm concerned, I think, that even at that level, that they're not as clear as you were today, I think, about the statistics. And I think that's why I think your point about having this happen in clinical practice is even more important. But just how clear are they in the informed consent process for clinical trials?
Thanks very much. So first, I just want to underscore, so at least in research, there's an informed consent process. It's refereed by ethics review boards, et cetera, whereas in care, there isn't any process at all. Basically, you're signing just a one-page document. So there's a process. Now, the question is that process optimal and appropriate? And the answer is absolutely not. If you look at most early phase clinical trials and you go to the benefit section and you read the language there, the typical language that's used in these consent documents is something like, it'll say, you may or may not benefit by participating in this clinical trial. Now, if you think about this from a probability standpoint, that's essentially saying your probability of benefit is somewhere between 0 and 1. There's absolutely no information contained in that statement. It'd be much better if consent documents made clear that you're almost certain to experience some side effects. The odds are pretty good you're going to experience, major, serious adverse events. But the prospect of major benefit in this trial is extremely remote. That would be much better if consent documents were clear about that. And so oftentimes people evade that information in consent documents and consent discussions. But again, at least there's a process in research, whereas there isn't really much of a process in the context of care.
Thank you very much for a great talk. It was really clear and convincing, and I'm really with you on all of this. I wanted you to expand a bit upon studies of what's actually happening in practice. because you were showing all the good reasons for why things shouldn't happen. But I was wondering about like what do we actually already know about, on the one hand, the push factors for people entering all of these experimental treatments. I'm thinking of Sharon Kaufman's work on it being not only the patient but also the family making a lot of different, engaging a particular social form of saying nobody's allowed to die. So you would, it becomes a social dynamic in families as well to push for some with no limits. Tolstoy in Anna Karenina has this famous passage where he says, the most important thing a medical doctor can do when somebody is ill is to try to persuade everybody into having the feeling that everything that could be done has been done without actually harming the patient. And I was kind of thinking of the social dynamics. The other aspect was, what do patients actually do? You were mentioning exceptions. And the AIDS activists. I have friends who were hacking the AIDS trials, so they were entering 3 different trials, and that's how they, participated in creating free combinational drugs. And I'm kind of thinking, a lot of patients already do a lot of different things. So how do we create a learning environment where we actually learn about what they are doing? Because in many cases, they are not following the medical logic anyway. So could you expand a bit upon, like studies of the practical dynamics involved and how we react on those?
Sure. I'll just say, so it's a really expansive question, and it's a question that, it's a very important question. It's a question for which I don't have especially deep expertise, but I have a few thoughts. One of the interesting dynamics that I've seen written about in the context of early phase cancer trials is that oftentimes physicians are very, very uncomfortable having to explain to a patient that they've reached the end of the road, that they really don't have a viable treatment option. So there's a guy named Matthew Miller who years ago wrote a wonderful article in the Hastings Center report, and he argued that a lot of what's going on in early phase trials, at least in cancer, is that physicians are trying to postpone as long as possible that discussion about not having an options. And so they offer patients participation in a phase 1 trial. And in fact, I've seen that personally. I've actually watched consent discussions in phase 1 cancer clinics. And in many times, phase 1 cancer clinics are typically very specialized centers. And so you have community physicians, community oncologists who are referring their patients to participate in those phase 1 studies. Oftentimes, those community physicians refer patients who have very advanced disease, who don't have adequate performance status, to participate in that clinical trial. And part of what they're doing, at least I've been told by people that run these clinics, these phase 1 clinics, is that those community physicians don't want to have the discussion with the patient, and that they're basically turfing to the phase 1 clinic that discussion about end of life. So I think that there's a really important psychological and affective dynamics that are happening actually within medicine in terms of how patients how physicians talk to their patients. I haven't so much answered your question about family dynamics, but I think there's a really important dynamic there about physicians being comfortable with explaining that they really don't have a viable option for a patient and making peace with that. Your second part of the question, remind me, was about... Oh, right. Okay.
How do we actually engage that kind of experimental knowledge that they have? How do we learn from that?
So yeah, certainly there were many, you can think of many examples. The most prominent example is, HIV/AIDS activists. People were mixing their medicines so they, no one would take the placebo, et cetera. I actually don't know. I think it's fairly common for patients to try to subvert clinical trials, at least in terms of subverting the blind. Patients intensely want to know what treatment arm they've been allocated to, so they might do various things to try to figure out, what treatments they're on. There certainly are cases of wealthy, patients who have tried to buy companies, for example, in the United States in order to access new interventions. But I'm not sure how generalizable the experience of HIV/AIDS activists in the 1980s and 90s is to the contemporary setting. I'm not sure how active and organized most patient communities are in trying to subvert the clinical trials process the way they were in the 80s and 90s. And actually, even if you look back in the 80s and 90s, there was a lot of HIV/AIDS activists actually repudiated some of that subversion, in part because I think they recognized that actually prolonged the innovation process. But I don't really have anything more sort of sophisticated to say about that particular issue. It's an interesting one.